Introductions. I'm Ted Kastner, Commissioner. Go this way and we'll go around.
Jill Pettinger, OPWDD.
Allison McCarthy, OPWDD.
Kate Marley, OPWDD.
Joel Rahat, Constable Choice.
Sankar Sivnath, iCircle Services, CDS.
Andrew Sionat, iCircle Services.
Maxine George, the Alternative Living Group, Inc.
Shamika Andrews, Self-Advocacy Association of New York State.
Arnold Ackerley, Self-Advocacy Association of New York State.
Brad Pivar, the State Advocacy Network.
Morning, Donna Colonna, Services for the Underserved.
Gary Weisskopf, Associate Commissioner for Managed Care at the Office of Mental Health.
Eric Harris, OPWDD.
Tamika Black, OPWDD.
And we're just going to start with Tamika's presentation on data and some of the things that we're working on.
Okay.
We'll have a discussion afterwards.
Thank you, Commissioner. Good morning, everybody. Hopefully everyone can hear me. I'm a little under the weather today, so just bear with me. I'm very excited to have a conversation about using data to support quality outcomes for people with IDD. The purpose of today's conversation is to review OPWDD's data strategy. We're going to outline the IDD Health Home Program, including goals, life plan development, and quality and performance measurement, and provide an overview of the life plan data system, including goals and data flow. For those of you who were present at the DDAC meeting yesterday, we did do a high-level overview. Today we have slides and a little bit more detailed conversation about what is in the life plan data system and the care coordination data definitions. OPWDD has really embarked on creating a data strategy, and the purpose of that strategy is to promote accountability and transparency for individuals, families, providers, employees, and stakeholders. We're also interested in providing accurate and timely and actionable data to support effective decision-making. And data-driven decision-making is something that we're really putting at the utmost importance at this point in time as we think about system transformation. We also want to ensure that the integrity of the IT systems being used are an appropriate source. As many of you know, the IT systems are only as good as what you put in it, and also the IT systems are only good as their sort of currency, meaning that OPWDD has many systems that were created in the 1980s and 1990s, and we're looking on embarking on establishing newer systems and ways of integrating those systems. We also are interested in balancing quality and performance reporting with assurances around person-specific confidential data, and that those things are handled appropriately. One of the things we want to use data for to support the design of IDD services and supports and evaluate their effectiveness. We also want to ensure equitable allocation of resources, and again, we want to contribute to data-informed policies. Yesterday I spoke about our data strategy components, and this is a graphic, and hopefully everybody can see it. But the components of our data strategy really start with our data roadmap. And the data roadmap is a high-level milestone document for achieving our strategy. Our data governance process is really about ensuring accurate and reliable sources of data, and again, safeguarding data with privacy and security controls. We also are interested in data sharing, and we've developed data use agreements to be able to share data, and we've become very more adept at understanding data use agreements and how to leverage those. Thank you, Josie. As part of our data strategy, we also have a quality strategy, and that's about monitoring service delivery and provider performance. It's our IDD clinical advisory group, which I'll talk a little bit more about during our presentation, and exploring the development of new quality measures. And finally, our strategy includes open data, and that's public-facing displays of aggregate data, which we're currently working on. When we developed our roadmap, there were 5 key areas of focus. The first one is enterprise data governance, and that's really the structure around our data. Who do we share data with? How do we use data? Big high-level policy decisions about the use of data. The roadmap also promotes innovation. We want to become forward-thinking as an agency and as a system, and our roadmap encompasses those key principles. We also address data access and use, who gets it, how it's used, our IT infrastructure, including our legacy systems, and again, looking at modernizing some of those systems and how those systems interface, and again, security and privacy considerations. two of the key areas in terms of measuring performance for OPWDD DOH initiatives are the reconvening of our IDD clinical advisory group, as well as enhancing health home performance. And I'm going to talk about the IDD CAG, and unfortunately we have one of the co-chairs here, Jill Pettinger of the clinical advisory group, and I think we'll talk a little bit more about that. So in terms of the CAG scope, as I mentioned, the first CAG was convened in 2016. We reconvened the CAG again in 2019. And we've been working really carefully and mindfully regarding quality measurement around the VBP roadmap. And the New York State DOH, or New York State roadmap, is available on the DOH website. The clinical advisory group is intended to make recommendations and provide feedback for quality measures for IDD populations. The CAG also presents the recommendations to the Joint Advisory Council. So at the end of the CAG's work in a given year, the Joint Advisory Council would review the recommendations from the Clinical Advisory Group. Once the JAC has reviewed those recommendations, they are then submitted to the Department of Health. We ask for a 2-year commitment for those who are on our CAG, and we also have relied on the clinical expertise, industry knowledge of IDD services and populations for our membership in terms of selection. In terms of the CAG roadmap, we anticipate 4 meetings in 2020. We meet quarterly. In meeting 1, the focus will really be on selecting measure evaluation criteria. What is the framework that OPWDD and DOH will use, as well as the members of the CAG, to select measures? Part of that is identifying chronic conditions or health problems for IDD that we believe are relevant, and identifying existing measure sets and how they may address chronic conditions for health problems for IDD. In our second meeting, we want to apply those evaluation criteria and discuss covered services and benefits and analysis of existing measure sets using that criteria. In the third meeting, we want to prioritize our quality measures once we've selected them, and we want to prioritize them based on feasibility. We want to look at an environmental scan of how other states are using quality measures and other considerations. And then finally, we want to issue our recommendations based on the year's work and review the completed work and recommended measure sets, discuss a cycle for reviewing measures ongoing, and review the scope of work of the CAG for future meetings. The IDD Health Home Program, so we talked a little bit about the CAG, which was part 1 of how we're thinking about performance and quality. And the second part is the IDD Health Home Program, or CCOs. That program is administered in collaboration with the Department of Health, and it really focuses on person-centered planning to develop life plans. Care managers provide enhanced care coordination, and we are delivering services in a conflict-free case management environment. The IDD Health Home program has 6 core services, and they're comprehensive transitional care, comprehensive care management, care coordination and health promotion, referral to community and social services, individual and family support, and HIT to linked services. All health homes provide these services, including the IDD Health Homes. One of the key features of the IDD Health Home is the life plan development. And we view the life plan development as a comprehensive assessment process that informs key aspects of the life plan and the individual's life and what they aspire to in their life. It's collaborative and reoccurring, and it's driven by the person. It describes who the person is, what they want to accomplish, what will help them accomplish their goals and valued outcomes. It's intended to integrate all services and natural supports, be understandable to the person and their families and stakeholders, and it must be agreed to and signed by the person and their interdisciplinary care team. In terms of enhancing capacity for IDD health homes, there are 3 key areas of focus for OPWDD. One is technical assistance. Many of you may have heard about the technical assistance reviews and the designation reviews that are being conducted by OPWDD staff, as well as the Department of Health. Allison McCarthy, who is part of our our managed care implementation team, is in the process, oversees some of that collaborative work with the Department of Health and making sure that there's quality in the development of life plans and the administration of the CCOs. The second piece of that is the life plan data system. It's the system that allows CCOs to share key data elements from the finalized life plans with OPWDD. The goal is to assist us with helping monitor life plan quality and help us calculate the quality measures that are in the CCO RFA or the CCO application. Finally, we hope to create dashboards and use those to monitor performance of the CCO health homes on key process measures. So that three-prong approach is intended to really focus on how we collect and use data from the care plan. The first thing I mentioned, and I mentioned it previously, is that we want to calculate CCO performance measures. We want to ensure risks identified in the assessment tools, such as the CAS or the Coordinated Assessment System, are addressed in the care planning process. We want to better monitor preventive health care. We want to analyze aspects of care not identified in enrollment and payment data, improve linkages of OPWDD services to specific outcomes, and support emergency management. There's also a health information technology platform for all of this data collection and data sharing, and I want to talk about three of them, and I hope you are familiar with them. The first one is the care management system that's used by CCOs, and it's known as Metasched. It's intended to document and create the electronic life plan, and it meets OPWDD's defined minimum data set for health home services, which is the care coordination data definitions. So we'll move on to the care coordination data definitions, or the CCDD. That defines the minimum standards for care planning and the sharing of data elements. It ensures care systems are used are consistent with federal HCBS standards, and it provides, again, a consistent data set across all care coordination IT systems. And it says CCDD here, but it does triple Ds, but it should be CCDD, is vendor agnostic. And what that means is that irrespective of the care coordination platform, in this example it's Metasched, but it could be another vendor, the ability to transfer data to OPWDD is a standardized format irrespective of the IT platform. And finally, the life plan data system. That's where the data is stored. So once it's transmitted in the format specified by the care coordination data definitions, it's stored in the life plan data system at OPWDD. It supports the quality measure development. The data in there is going to be extracted and used for research and analysis, and it also supports OPWDD oversight and compliance for care planning. So in terms of how the data exchange works, hopefully everybody can see this flow. It starts with the person-centered planning process with the CCOs. So many of you know that there's an IM assessment which helps develop that life plan, and we more or less call it more of a tool than an actual assessment. We believe the CAS is really the clinical assessment that helps with acuity, but the IM is a tool to help develop the life plan. Once the life plan is developed, it's basically stored in the care management system or Metasched. The care manager enters information about the person and their life plan. The CCDD extract is the data elements that get transferred to the life plan data system at OPWDD. From the life plan data system, staff extract that data, analyze that data, validate that data, and create quality measures. And then ultimately, we'll be creating an OPWDD dashboard. So the care coordination data definitions, and we talked about that being the document that establishes data standards between OPWDD and the CCO health homes. And again, these data definitions allow the care coordination providers to share specified life plan data. And the CCDD can be found on the OPWDD website. It's right now a 102-page document. So we're going to talk a little bit of a high-level overview of what's in the CCDD. So I know this may be a little bit hard to see, but the CCDD comprises 11 sections. The first section outlines and collects demographic and profile information. When we say demographic information, information about the individual. Their ID, their date of birth, their address. It has billing information, it has CCO information, who's the care manager. All of that information is identified in the first section. It has 51 data elements in that section. The second section are outcomes and support strategies. In this section, which I think is of interest, it identifies the valued outcomes and the action steps to achieve them for responsible parties. We talked a little bit yesterday about drop-down boxes and whether these things were being fully captured in the life plan as well as the CCDD. This is the section where, again, individuals identify valued outcomes, and then there's action steps associated with each valued outcome captured in the system. This third section is health and safety, or the IPOP, and it's information on safeguards and supports and whether they're existing or not existing for that person. Section 4 is authorized services, and that are the authorized HCBS waiver services, and it documents each waiver service that the person is authorized for. It also includes provider names, identifiers, duration, units, frequency, and self-direction data. 5 deals with natural supports and other services and community resources. These are text or narrative descriptions, so we have a combination of both numerical fields, character fields, drop-downs, as well as text or narrative fields. And again, it actually captures natural supports, frequently used community resources, and key healthcare provider info. 6 focuses on preventive medical planning, and again, dates of recent or key exams, tests, prescribed medications, and recent hospitalizations. 7 captures information on behavioral supports needs, including psychiatric conditions and behavioral supports. 8 is employment, and it's information on paid competitive employment. 9 is a section that was intended for future use, ultimately when we went more in a managed care framework, but it's a summary results of the most recent CQL POMS interviews. There was intended to be a sample from each of the MCOs, the managed care plans, and then looking at those results. 10 is a Willowbrook supplement, which applies to class members only in the Willowbrook class, and it's information on representation status, community inclusion, hospital staffing coverage. 11 is temporary, and that's risk factors. It's the risk of falls, choking and aspiration, a desire to pursue employment. It's intended to be replaced by the CAS when the CAS is fully implemented. The next slide talks about the quality measure process, and I wanted to explain this in a sense that quality measurement is an iterative process, and we've come a long way over the last 2 years in terms of the implementation of CCOs and beginning to think about data exchange and collecting data for quality measurement, and also informing policy decisions made by OPWDD as well as the quality of the system. Oftentimes, measurement design occurs without the benefit of data when a new program is being implemented, and that was the case of the CCOs. The application went out before we even had a CCO implemented. We had to kind of estimate where we thought the relevant data would be, what was important to the system, and what we thought we would capture. At that particular point in time, we drafted these measures in response to those federal requirements, and they're considered to be a starting point. Measurement is a journey, and we are beginning that journey now. And we also recognize that some of the things that we would like to measure about the system may not be immediately measurable. We're just starting that data collection process, and the implementation process continues. We also know that measures may change over time based on programmatic experience, and when we look at data, we mine data and analyze data. Additionally, measures and specifications are being developed and will be refined as, again, we validate and analyze the information that we receive, and we clean that data and we make sure it's reliable. The other thing I wanted to talk about is measure specification, and I know sometimes it's very frustrating, especially for stakeholders when there's a desire for data and information. And one of the things we look at is how to actually capture data in a systematic kind of way, and that it's reliable, that it's valid, that we can trust the information, we can entrust what it's telling us. In order to do that, we actually specify the measures. We have a framework of parameters around those measures. We have to describe, we have to name them, we have to describe them, we have to really clearly identify the intended use. We really have to focus on the data elements, and that's what the care coordination data definitions are. They're data elements. And those are the key terms, the codes, the system codes, and the value sets of what's being captured. Then when we identify a measure, we have to also think about the numerator and denominator. We have to define who's the eligible populations or the defined populations, who's excluded, and what are the instructions for calculating those results. We also have to look at the data collection and the tools, where the sources are, what are the methods, what's the time interval for collecting that data, what's the reporting period. So there are a lot of things to consider so that everybody's reporting in the same way, in the same fashion for the same thing. And then we also have other factors such as the care setting and any kind of risk adjustment for maybe the acuity level of the population, and what's baseline, what do we consider to be improvement from baseline. There's also measure evaluation criteria, and this is the framework similar to the framework that the clinical advisory group will be using. We're looking at the relevance of the measures. There's tons of measure sets out there right now, including those measures that are in the CCO application. When we're evaluating measures that OPWDD would like to adopt, we really want to focus on a few key areas. And again, the relevance is whether the metric is useful for quality reporting and decision making, as agreed to by the group and stakeholders. Can the measure be used for the required level of measurement? Meaning, are we looking at individual? Are we looking at provider level data? Are we looking at the system as a whole? We also need to determine whether the measure is valid and whether it's correct, it's free from systematic errors and bias. And we also want to be able to make sure that we can make accurate conclusions around that measure and the measure score, and that they accurately reflect quality. We want to make sure that the measure is reliable, it's well defined, it's precisely specified, it can be implemented consistently, and it distinguishes differences in performance. And then finally, we want to make sure that the measure is actually feasible, that we can actually get the data for it, that it's available, and that it can be captured without undue burden, and it can be implemented for performance measurement. For anyone who's interested, the IDD Health Home Performance Measures are actually available on the OPWDD website, and the specifications are available there too. We recommend that our ID Health Homes monitor this specific measure set until actual reporting to New York State begins. We're hoping that the health homes are using their own systems, including Metasced, to really look at the measures, mine their own data, look at these things before the actual reporting to New York State. And again, these measures focus on important aspects of enhanced care coordination and management as it relates to the development of the life plan. This slide might be a little bit hard to read, but it actually outlines the key measures that are in the CCO application right now. The areas are the implementation of CQL POMs, implementation of personal safeguards, the transition to a more integrated setting, employment, self-direction, bladder and bowel continence, falls, and choking. And here's an example of the numerator versus the denominator kind of calculation. So example for the implementation of CQL POMs. The numerator are the number of IDD members with life plans with a minimum of 2 POMs measures. And the denominator is the total number of IDD members with life plans. So you get a proportion, a ratio, or a percentage. And those are the kinds of things that we're doing, and each numerator and denominator has to be specified. And then there's even additional specifications beyond just the general categorization of the development of the measures. There is also an additional measure from CMS, and this is what we talk about when we say measure sets are evolving. Measurement requirements may shift over time. We also may find that as we've resolved or gotten high marks on certain benchmarks or performance standards, that there may be new areas of concern or new areas we want to look at and would develop measures for those. In this case, CMS is interested in, for all health home programs, including the IDD Health Home, the number of admissions to an institution among health home enrollees age 18 and older residing in the community for at least 1 month. What's interesting about this measure is the specifications for this measure are 6 pages long. It is complicated. Actually, the specifications are very easy to read. It's just that it's very detailed about how you calculate it to make sure that everybody's including the right population, the right number of people, identifying what it means to be in an institution, what it means to be in the community. All those things must be defined and clearly outlined so that everybody's looking at it from the same perspective. OPWDD has really completed work in early 2019. We engaged NISTAC, which is a consulting group that's been assisting us with crosswalking the care coordination data definitions against national standards for healthcare data exchange. We want to make sure that we're consistent both with national as well as our own state interests. We've done ongoing review and update of it's the CCDD requirements, and the Metasced review of the CCDD and care coordinate and IM systems for gap analysis. So we're always looking to make sure that we have everything covered. In terms of recent work completed in 2019, in September, October, we began testing of the secure connection between CCOs and OPWDD, and that connection is what we'd be using to make sure we can securely transmit data. In November 2019, the CCOs actually reviewed the Metasced system mapping to the care coordination data definitions. So that's making sure that the data elements in the CCDD actually map correctly to the right fields in the Metasced system, and that data is being captured and transmitted appropriately. The testing of the connection was completed in December 2019. In late December, we're intending to respond to the CCO's request for clarification of data fields and privacy and security concerns. So we're working on those clarifications. The CCOs have done a great job with their subject matter experts, identifying potential issues with the mapping between the CCDD and the Metascat system to make sure we're fully capturing the right fields, that care managers use those fields and understand those fields. So we're in the process of responding to the CCO's request. In January, we hope to transmit full life plans with test data, so it's not real data, it's test data. By March 2020, we hope to transmit actual records for all CCOs. Between April and December 2020, we want to create test reports, validate the data, and do any correction activities that are necessary. So now I wanted to open up for discussion, and Commissioner?
I want to thank you for doing that. I think what you're seeing is kind of a response to the fact that OPWDD launched the CCO platform very quickly, and all of you who are involved in that process understand what a complex transition that was. For our part, we lacked access to the data that was being created as a result of that transition. And this is an example of building the plane while you're flying it. It'd be nice to have had this 2 years ago. And we could have had that up and running on July 1st of 2018, but we didn't, and it's great to see that we're going to. Obviously, this is mostly CCO-related data and data infrastructure. We have a fair amount of time, and I think it's an opportunity to have a discussion really about the broader issues around data. I've been meeting with folks around the state for the last year and talking about, 3 elements of our mission that need to be addressed, and I think data is a key element of that. We've got to ensure that we have a system that's accessible, that we can allocate the resources we have in a fashion that's equitable, and that we also have a sustainable system. And I think those 3 goals speak to what we're trying to accomplish with CCOs, but they're also goals that we're trying to accomplish relative to all of our program development, all of our work with our provider partners, the manner in which we support individuals and their families. So I would, like to, in the next hour and a half, spend the time, if you'd like, talking about data in a more broad fashion, looking at opportunities to use data to help us direct and guide our system in terms of what things we might emphasize or de-emphasize. Certainly to look at issues around program development and CCOs, but program development and program evaluation and other programs that we operate. Issues around public reporting, making data available to consumers, individuals, families, and other constituents. We can use data for budgeting, which we currently don't really use. We use CFRs. There are opportunities to look at data for budgeting and also in the context of payment methodologies. And finally, in terms of the issue of sustainability, which I think is critical to our future, we can use data for actuarial purposes. We've not talked about doing that, but it would be very helpful to give data to actuaries, data that reflects the current growth in the number of individuals we serve, the requests for services, and the types of services that we're offering. So we have a fair amount of time, and I'd like to open that to she's had her hand up for a bit, so we'll start.
Thank you. This is my second time in a couple of weeks, Commissioner, and Ms. Black, that I've had the opportunity to hear you speak so eloquently on the data collection and your strive to get this in place so we can hopefully have a better system to manage how we do business. The data is really wonderful, and I'm glad we're going in this direction because and I encourage you as you roll out this data to mean something to us, that it will be shared with us so that the field can understand where we're going with that, and that it is understandable. We sometimes get bogged down with minutia. Not that you are, but I really like this data collection. In sitting here and listening to the presentation, I would like to get back to how we are going to measure consumer satisfaction. I'm hearing a lot of things about data and a lot of correspondence or shared information between the CCOs and the state of New York, and using that information to set the course for us. I strongly urge OPWDD to look at ways in which it can collect data from families that is independent of the CCOs in the state of New York. I think when you speak with families about what their experiences have been with the CCOs, there might be some conflict in what you're hearing on the other end. So as you're developing this data collection side by side, I would like to suggest that we focus in on the individuals who are receiving their services, the experiences that the families are having, and putting that information in your data collection as you move forward to develop additional systems and funding allocations for this very vulnerable population. It's a voluminous amount of data you're collecting. I wish I'd had the slides that you've shared here, and it seems to be very, very well thought of. I'm very impressed, so that we could have reviewed it before coming here. I'm all for data, but I think that we can get so bogged down in it that we are really not seeing what we need to do and achieve here as the state of New York focuses on the future for this population. That's all.
So you sound like me about a year ago when I first met Tamika, and I run in the door, I say, okay, where's all the data? No, it's good, it's good. Like, where's all the data? Let me see it. And then Tamika comes back and says, there's a 6-page document just on how to define the numerator and the denominator for a specific measure.
Yes.
So I'm beginning to appreciate the complexity of a data strategy, and that it's not just that there's a candy store and I run in and I grab as much as I can. There's a lot more thought that has to be put into it. Now, certainly, individual satisfaction, family satisfaction are really important areas to evaluate and measure and to analyze and report. Having said that, there are lots of points at which our system, OPWDD, CCOs, providers, contact our individuals and families, that we interact with them. And so the question of, how do you evaluate satisfaction or understand the experience of our individuals and families is really, really complicated.
It is complicated, but however, I do believe that it is achievable in small parts. And as I said that, it's to me, I see a conflict of interest in having a CCO evaluate their own services or go to their constituents to receive some type of evaluation outcomes. I think it should be an independent process by the state of New York. When a case manager sits with a family member or those who are providing services, and there are still families who believe that if they're not nice and they don't play nice, they won't get what they deserve. So I believe, and I strongly encourage the state of New York to look at how it can get to the satisfaction piece. I do still have families who are unfamiliar with the MSCs, our care coordinators, who have not connected to the new life plans. It sounds pretty, but in its final outcome is, what is it are they getting from this? Are they truly involved and satisfied with the services? So I go back to conflict of interest of how we collect data.
So that's a concern that exists in all settings around data. For example, with managed care, there's a satisfaction element called the CAPS survey. That's administered by a third party, separate from the managed care organizations, and then that data is provided both the managed care organization and the state. Similarly, in terms of enrollment, enrollment brokers are used, third parties, to assist people in choosing managed care organizations. So the issue of conflicts and arm's length relationships around collecting data is really important. I can't say that we have a specific plan, strategy, recommendation, but it's a really important issue, and we'll take that into account as we start building. Yep.
Commissioner, I did want to add that we haven't given thought to the notion of satisfaction. There are two areas that do currently currently exist for us as potential opportunities. One is the national core indicators data that individuals do fill out, and the other part is the person-centered review, which is administered through our Division of Quality Improvement through our survey and certification process. And that's the part where the surveyors interact with families, individuals, ask questions about their service delivery and care coordination and care management. So those are potential opportunities, and we're looking at the kind of information we get from those key sources and how they can help us give an indication at this point in time. But we do understand what you're saying in terms of really looking at satisfaction, and the Commissioner's correct. There is a clear avenue under managed care with the CAP, but we're looking into it.
Thank you.
Thank you, Commissioner. It was really a great presentation on collection of data within the CCO. And I just wanted to ask it looks like you're looking at a larger construct as well beyond the CCO. Right now, how you're building it out. And for us, as one of the emerging CPLs, the question for us is, where do we go from here? And you've talked about the CPL and the quals document. And I was wondering if you could share within the continuum of what you're developing, where does that fit? And can we see a timeline or anything to that effect?
Sure. So let me just tell you what I can tell you about the CPL qual doc. Back in September, we were given the approval by the chamber to announce publicly that the revised qual doc would be made available for review in either late October or early November. Now, obviously, we're well past those timelines. At the present time, I can tell you that the qual doc is under review by internal stakeholders, and it's not available for publication at the current time. We don't have any guidance as to when that might occur. Obviously, the challenge in state government in the next month will be the budget, and I fear that the more we get into the budget process, the less likely it is that the qual doc will be, made available for review. Everyone will be focused on trying to get the budget done. So
could you talk a little bit, Commissioner, about the long-term strategy you might have as you look at development of the CCO? What's next on the managed care path? Allison is talking about, implementation of managed care. How will it work? If the CPL document doesn't come out, what's your vision? Where does it fit in terms of the managed care? Yeah.
So then I'll just if you want to kind of talk about a trajectory, let me start from where we were,
Sure.
Which was pretty much operating a fee-for-service program and a fee-for-service case management program that was very, fragmented. So I think the first step, tangible step in moving towards managed care was to launch the CCOs, to create a more consistent, unified platform for care coordination, and to take the step of integrating healthcare services with long-term care services. So the ISP became the life plan, and that really wasn't, in my mind, just a matter of changing the name or the words, but incorporating a broader scope for care coordinators and focusing on trying to integrate health and long-term care services in a way that created more value. And we're still in the middle of that process. I mean, CCOs launched 18 months ago. By the end of this month, we will finally be at a point where everyone has a life plan. We're now beginning to look more carefully at what are in those life plans to try to assure everyone that they're effective and appropriate and that individuals can access their care coordinators. So Allison's team has been meeting with CCOs, talking about the more qualitative aspects of CCO performance, how to measure that, and make that information available to the public. Yes, I know where you're going. So that's kind of the beginning of the trajectory.
Right.
So as far as the CPL qual document, it was first published in August of 2018. We received 75 to 80 public comments. The stakeholders internal to government have been working on trying to incorporate those comments into a revised CPL qualifications document. And OPWDD does not work in a vacuum. We work with stakeholders, and the obvious stakeholders are Department of Health, Medicaid. We often work with OMH. They're very smart and have helped us a lot in understanding the transition to managed care. Other stakeholders include the Department of the Budget, Division of the Budget, and other governmental elements. We have done our work, presented it to the Chamber, and the Chamber is considering what the next steps are. And
I just wanted to add to it. OPWDD partnered with providers who were interested in getting into managed care to set up these organizations. They provided seed money to do it too. So we've set up these infrastructures, and we now are seeing the evolution, the transition to CCO, and then the next was going to be, let's keep moving toward complete managed care. So we have an interest, and we know you have an interest, and we're just trying to figure out, maybe we'll have a separate conversation on this. But
I think it's helpful for the larger audience to understand that at the point where we currently are, OPWDD has completed its work, and it's with the Chamber. The Chamber makes the decision about where we move and how we move and when we move. So we are at a point where we can't provide additional information in terms of timelines or content or direction. So as much as you would like to know, I think we would like to know also.
All right, thank you.
Joel?
Now it's on. All right. An independent party measuring satisfaction, which I think is really important. A couple of things to note on that front. In the managed care side, I can speak specifically to the managed long-term care side. On the MLTC side, iPro conducts a survey for the MLTC population once in 2 years. They send out satisfaction letters, and there's a lot of good quality stuff in there. But one of the things that they measure, and they speak directly to the individuals or members in a managed care environment, they also measure the performance of not only the managed cares, but also the performance of the individual providers. Because I think as much as we want to, as in OPWDD and DOH have done a really great job over the last 18 months working closely with the CCOs, we cannot forget the fact that the CCOs have a prime job to do, which is link, advocate, and connect to services and promote services for individuals. And then there is hundreds and hundreds of providers out there who perform the actual services every single day. And I think if we do an independent review, which is welcomed by all of the CCOs, it's got to be comprehensive and looking at both sides, not only looking at a side from a care manager's perspective, it's got to look at every other element, including the fee-for-service providers on the waiver side, on the health side, if there's individuals who are getting home care services or access to doctors. It's really important. I think there's a lot of valuable information that we can all learn from having an independent satisfaction view and getting a good understanding of what is really happening on a day-to-day to our individuals and families. Because a lot of individuals and families, I can tell you from a CCO perspective, they went through the front door process, they went through the evaluation process, their CCO was submitted, and they're now in the CCO enrolled. They think that they're going to have the help tomorrow, and they don't realize that, no, this is just the beginning. Then for the next 60 to 90 days, their care manager will get to know them, do the IM, get the life plan done, and then once this is done, then the search for services and the setting up services and then making sure that services are delivered in a satisfactory manner, that all begins. That's a very, very long process for individuals, and it takes a long time. And I think it's important to constantly keep an eye on the full spectrum of things. So it's not only, we're pleased that we're at that point where individuals who were in the system before July 1 of 2018, they were all relying on the current ISP. So it's not that they didn't have a plan. They were having an ISP, but the full transition took 18 months, but we are now at a point, at least for our CCO, we submitted the report yesterday, and we have a life plan for every single individual in our CCO. There's 16 net new individuals who enrolled in October, so they're still within the 90-day time frame, and their life plan will be completed by the end of this month. So I think there's progress being made, but there is a lot more to look at. So we welcome the opportunity for data, and we also welcome, and I just want to comment that I think having an independent satisfaction check speaking directly to our individuals would be a great idea, because it can measure the satisfaction rate on the full spectrum. So,
thank you.
Yeah, I want to follow up. That was a good comments, I think. Thanks, Tamika. I actually watched it on the WebEx yesterday too, so I'm going to retain this. I'm going to memorize it pretty soon, but it's good. You got to start somewhere, right? So I think this is really important work. So if you think about basics, just collecting data from a life plan, or demographic information, and this is real. Talk about iterative. This is my experience, and Gary's sitting next to me, OMH, but in the health home world, which we started in 2011. It was a long time ago. We're still struggling, by the way, with connectivity, with data collection, getting access to data. So data has to come from multiple sources, right? And so you want to have data to support an individual on an individual level, as well as a population health, possibly, because there's some stuff you can really learn in terms of the population. And so I think this is really, I know if it's been said, iterative, but I think to your point about the more comprehensive view of things, at least the experience really is care coordination is one aspect, and the challenge, I think, with care coordination experiencing in the health home world is that oftentimes the care coordinator doesn't have the teeth, if you will, or the gravitas to really care manage all the different pieces of that, the health world, the long-term care world, in the case of behavioral health, the behavioral health world, and that unless there's connectivity to a total cost of care approach, whether it's a plan, in our case, because we're mandatory, it's a plan, the care coordinator oftentimes is out there. And to your point, Joel, that the underlying providers really have to be held accountable. And so oftentimes, whether it's the CCO now or the health home, we're really not in a position to do that in real terms. I mean, I think a lot of it depends on goodwill in terms of the organizations working together. The healthcare world, the long-term care world isn't necessarily our world in the DD world. So influencing that world in support of the individuals we serve is often very challenging. So, but I do think that these are the kind of conversations that we have to get to if we're really interested in real integrated care. We also have to begin to collect data. So as it struck me that when we get the basics data, the interaction with the underlying providers, where's that data coming from, right? So how do we involve reasonably, because, we're going to get pushback, well, we have so much to do now, you want us to collect more data. How are we going to be interoperable from an underlying provider standpoint? Because otherwise it's a standalone doc, which may have value because it then lays out, connected to the CAS and the IM and the life plan, and is it truly a participatory document with respect to individual and the family, but we don't then have the other data that have they been in the hospital unnecessarily, all the health-related issues, do we know what's happening out there? Where are we getting that data from? We're not connected to claims data. We're not connected to... So oftentimes, even in organizations, we struggle with sort of trying to collect that data on an individual level from the health world, right? So in my mind, it could either get really big so that you kind of think, oh my God, like this is really enormous, or you just have to start. But I do think long term, and you start mapping out how do you connect to the rest of the data worlds, right? And we are in the behavioral health world still in our infancy with respect to data warehouse, if you will, where there's connectivity to plan data, claims data, even when learning when somebody's in a hospital and getting alerts to the underlying providers, and if it's not in the Medicaid system, how do you collect that data? So I mean, there's a lot to think about here, but you got to start somewhere. But to, so that's sort of my view of the world is like, they're building blocks here. But you do have to sort of really think about long-term, at least a roadmap that suggests, and long-term could be a pretty long time, how do we end up really collecting data in a way that's beneficial to the people we serve? And I do believe that if, on small scale, if you look at where, to the extent that we can, you can really learn some interesting things about how we can better serve individuals and how we interact with the other care worlds, whether it's healthcare or other long-term care fields. So I think it's the right direction. It's a little bit overwhelming in terms of, because we're just talking about really basic input right now, right? Which is great because we didn't have it as an OPWDD system, but there's a lot there. I don't know. But I think to your point, yes, independent reviews is very important. But I don't think we should lose sight of the fact that the CCOs are care coordinate entities, and that there's a lot of underlying providers we're relying on to really provide the direct service to the individuals.
And if I could add to building on what Donna said, some of this goes to the training of the care coordinators and how they perform their jobs. And it's interesting, we call them care coordination organizations. And then we call the care coordinator a care manager, which we are familiar with in managed care. That person really looks out for the person's whole life and helps to drive those activities that give the outcomes that you would like to see. And, that's why this push to managed care is so important, because right now we have care coordination. We've taken MSCs who are wonderful people who have been advocates, but they haven't had the teeth to actually manage care. And so how do we, when you collect the data, what kind of data are you collecting? Is it meaningful data coming from this care coordination system right now? And how do we build it as we move to managed care? I just wanted to add that.
Sure.
Yeah. So again, this is from an OMH perspective. We've had data. We've been using data for quite a long time. We've pushed data out to providers on care and care access. We look at it ourselves. It is a huge culture change for many organizations to actually take a look at this data and say, okay, well, what do I do with it? Because Donna was raising the really good point about, okay, it's care management, but what services are they getting? So we have a tool called Psyches, which is available to all the mental health and substance use providers and to all the emergency rooms, and there's a lot of information in there. You can use it for systems planning, and we're taking a look at this, and we're talking to providers, but a lot of providers, even large providers, aren't really set up to actually take that data in, change the way you do work. And one of the things that you have to think about with data is just how are you really structured to do something with the information. And I think as a system, I mean, at the state level, we have access to a lot of information, and it's a huge amount of effort from an agency point of view to get that information packaged in a way to get out to providers. But just my advice is that ultimately that's what's going to be required to get information in an easily usable way out, and then work with providers over a long period of time, because it's not an overnight thing, to figure out how you change the way you deliver care around that data. But it's ultimately the only thing that's going to improve care on a system basis, because without information, everyone is just sort of guessing.
Correct.
It's back on again. I did want to mention, and Gary, thank you for your point there, especially with the mention of Psyches, that as part of the IDD CAG, we have been looking at data systems in other state agencies to promote cross-system collaboration and trying to get a better understanding of the whole system. And so those PowerPoints are available on the Department of Health website. And Gary, so timely, because in one of our last meetings, we actually talked about the Psyche system. We talked about claims data. We talked about leveraging DOH IT systems and beginning to think about how to bring data from other systems and develop quality measures that look at that. It's, again, we're having conversations conversations. This is the beginning. And Donna aptly put that it's something that we do have to plan for. We're talking about it now. We're considering it. We're looking at ways we can get measures from and data from multiple sources, like national core indicators, like our own compliance activities, other state systems, claims data. It's challenging, but we really are beginning that process.
I would just add that Psyche started as a polypharmacy tool many years ago, and it's taken a long time to get to where it is. So these things really, they take time, but if you can build on something that's already there, maybe that helps.
So I feel like you're doing what initially my reaction was, kind of reach for the stars, and fortunately people like Tamika and Gary have their feet on the ground. And I think it helps us all understand that, there are lots of things we would aspire to do, but there is only so much that we can do right now. And I think the focus on CCOs is especially timely because it's the foundation for moving into managed care, building an infrastructure that will support decision-making later. And OMH has been a great partner and advisor to OPWDD. You have many years of experience that we lack. You've managed to build an infrastructure that we would love to model. There are a lot of things that OMH is very smart at doing, and data is one of them. So we're actually spending, I hope, a good amount of time working with you. I know I've met with the commissioner. We have dialogue at the senior team level, so it's been very effective and really, really helpful to us. Sorry, there was another question. Yeah.
Couple things. I was really very, very, very pleased to hear you say that you're.
Yeah.
Sorry. Thank you. That you're developing systems that will help us all speak, because that is very critical. When I come and I see the display here, I see a lot of things being said about Metascat, but Metascat is not the only game in town. It's we're just very fortunate in the right place and the right time to have been. Had a segue in some of the CCOs. But, we have agencies that are using different systems, and it's not compatible to really giving the information that you need. So if we can develop something going forward where it opens the gate where we can share information more easily, it would be wonderful. Point 1, 2. I would like to get back to the care coordinators. We are talking about a data-driven system, and I'm in full support because I believe that it's going to lead us to develop a better system for the future. Maybe not in my lifetime, but hopefully better for the future. I would like to hear from the care coordinators how much of their time is being spent data collection. What I'm hearing from many of the care coordinators and the experiences that our families are having is that they're so busy doing this data collection and spending time in front of the screen and not in the family's space as we once had some number of years ago before we transferred over to the CCOs. I can say that is a fact. There are meetings that they can't come to. There are some who, we do have families who are not able to read and comprehend. And when we had our MSCs in-house, they were able to help our families sit with applications and go through it and develop and respond to those applications and get the services. We're hearing some care coordinators stating that they simply do not have enough time to get back in to deal with this Metascat system. It's very complex. We're sitting here and thank God we don't have Metascat, we have another thing. But anyway, we have to speak with that Metascat sometime. But they're sitting in front of this screen and they're collecting a lot of data with Metascat. They're not able to come to some of the critical meetings that they once had in past years because they're just too busy with data and learning new systems as it goes along. I would love to hear from the care coordinators independently and anonymously how much of their time are actually spent with families and how much of their time are actually spent in front of the screen collecting data for CCOs.
Well, sounds like an interesting idea. Did any of the CCOs want to comment on that, or I don't know? Sure.
Well, I think that certainly the care managers are very vocal, and they speak their mind about dissatisfaction on certain elements of the electronic health record system, in this case Metascat. And so it is there is challenges with that system, but I would also say that we are still in the first 2 years. We are in the second year of transition, and this was a very, very big transition. And let's not forget, none of the CCOs created the conflict-free, mandate, so to speak, right? We were all. This came down from CMS, and OPWDD went along, and then the merging CPL, the merging CCOs came about, and this whole thing kind of happened one after the other. And then we had to transform a system where close to 100,000 individuals had to move over to what we call now an IDD health home. And the requirements, which none of the CCOs are setting, are set in stone, and we have to comply, right? And I think that the challenges with the system are what the challenges are. I could speak for our CCO. We have invested tremendous amount of time and resources and training and retraining the staff so that they could focus on the job, the number one job, which is to serve the individuals and to help the families. I spent my entire day yesterday in our Long Island City office where we had our quarterly enrollee advisory council, which is a mandate to all CCOs. So I spent a lot of time with parents and talking with them one-on-one and in a group. We had the physical meeting was in Long Island City, and then we had parents who wanted to join from different regions, like from the Albany side and from the other ends of the other counties. They joined by Skype, and we had a lengthy conversation about delivery of services. How do we make sure that we continue to focus on what is important to a family and individual on a day-to-day basis? But I think it's also important to acknowledge that there are still some challenges with this system or with any system. There's never going to be a perfect EHR system, that's for sure. But we have also invested a lot of time in developing resources. Like we have our CCO spent a lot of money on a resources portal to our care managers where they can go in, any care manager that we have in any of the 25 counties where we operate. If they are looking for any sort of provider, regardless if it's a waiver provider, a long-term care provider, a medical, like a dentist or anything like that, they can go in and search by county. We have established very strong relationships with all these providers. And then a care manager can go in after they made a referral for services, they followed up on that appointment, they can go in and post comments on how that visit went. So is that location ADA compliant? Were they nice and courteous to the individual who visited? Did they let them wait in the waiting rooms? Like stuff like that, really important stuff, which in a bigger system, there's the resources and the expertise to build that. And now we have families, for example, I know about a specific family who moved from Albany down to Long Island, right? And if we think about it, they were able to be followed through. The two teams got together, they built a transition plan, a physical transition plan, and then the care managers were able to exchange information on the portal and then in person on what are the needs, what do they need now, what do they need tomorrow. So I think all in all, care managers, I think it's important to acknowledge the challenges that they are having with the electronic health record system, and it's absolutely there. But as a CCO, we're doing everything we can to take care of these challenges and make sure that the focus is on the individuals.
Well, if a parent were sitting here, the parent would most likely say, I hear your pain, but your pain is not my pain. So I want to get back to, yes, we do know that there are challenges, but when we did this transformation over to the CCOs, I think we went at a speed that might not have been beneficial to families, not to the providers. But here we are. So it was not meant to create chaos in a family's life. Now, there are always wonderful stories to be told, and that we all can claim wonderful stories. But by and large, many of the families that we serve who are poor and disenfranchised, who are on the periphery of services, who have a very difficult time connecting to what we perceive as can be a bureaucratic system, who are technologically, they are challenged in that area, and now they have to deal, they have to change the way they relate to their their managed care, their case coordinator from a personal level into something that is technologically driven. So that type of culture takes time. I still would like to encourage the commissioner to look at a data collection. We're talking about data collection here. I would love to know how much time and it should not go to the CCO to manage this information. It should go directly, anonymously to the case coordinator. We would like to know how much time is spent in that office, in front of a screen, and not in the space of an individual, and how much time they have to cancel their appointments because they're too busy in the next training session. I'm going to tell you, this is a real issue. We are not dealing with packages. We are not Stewarts, and we are not Macy's. We are Office of Persons with Developmental Disabilities, and our individuals require personal care at times, especially the more disenfranchised they feel or are from the services that OPWDD provides.
So thank you again. It's not just an OPWDD issue. It's not just a CCO issue. This is an issue across the entire healthcare landscape. Over the last 10 years, most practices have converted to electronic health records. And there's a lot of dissatisfaction among healthcare workers with how their day is changed and the time is reallocated. And to your point, their inability to spend as much time with their patients or their customers or their clients or whatever we want to call them, as much time as they previously did. Personally, I've launched 3 EHRs. One in my practice. I launched Epic when I was at Montefiore. And while I was at Montefiore, we also were a delegated subcontractor to one of the CCOs, and we launched Metasced. It's a huge cultural change to incorporate the goal of data collection and to do so in a way that is built into an electronic system. When I sat with patients, I couldn't look at them anymore because I had to look at the computer screen. I significantly disliked it. It was uncomfortable. It was distracting, but it was a priority and a new priority, which took away from the other priorities. So what's happening in healthcare and is reflected in our CCO operations is that people make trade-offs. We make trade-offs at the level of systems, and I think what we are saying is that there is value in collecting data and organizing it electronically, and that trade-off comes at the expense of something else. And to some degree, that may be the amount of personal time and attention that consumers receive from their support. I'm going to say I agree. It's important to look at. We need to have more information about it, but we're going to come down to having to make trade-offs between one or the other.
But Commissioner, I would like to say, when I sit in my doctor's office, I know that I am just a number and I have a 15-minute increment of billing. But I'm not a person with IDD. If I'm not satisfied with my doctor, I can go elsewhere. And so we need to take into consideration as we're looking at these trade-offs to make sure that the trade-offs are not such that they are putting people in more serious positions than they were prior to entering the system. So we still need to look at how we can manage these trade-offs so that the persons are not lost in data, they're not lost in our attitudes of achieving outcomes that they are not even at the table at developing. So that's just...
I totally agree. The trade-off shouldn't be that you sacrifice the core function or the core mission of the program. So I completely understand that.
I also wanted to add, and I think, and I'm not trying to, be more specific than we really need because I think it's important to capture those trade-offs. But I think it would also be helpful in not just asking how much time they spend in front of the screen, but more asking about the differences. We've often heard about providers and MSCs talking about documentation and the amount of time of documentation. This was before an electronic system. It was when it was manual, and that manual documentation was taking them away from providing care. I'd be interested to know how people perceive the difference between what they did in a manual function and what they do electronically, and it may be more now. I would also like to know what they're attributing to the learning curve. Do people feel that, yes, it's burdensome now, but give me another year, as did when I had to learn all those paper forms? I anticipate it's going to get better, or I don't think it's going to get better because of. The other thing also, too, is learning about the trade-offs from an efficiency standpoint. And what I mean by that is that a care manager may be having a lot of challenges right now and may be seeing their amount of time face-to-face with individuals not be where they want it to be. But there may be some things that they've learned and appreciated about the possibility with technology. They've been able to better coordinate. They've been able to do other things. So I'd like to also learn about where they've actually maybe seen some positive gains. It's not because I think the screen time is important, but I also want to understand a balanced picture of the work that a care manager does. And if it's all one-sided and it's all down, I really do, I think we should also keep that in mind. Just that there's balance in just understanding, and then we can really evaluate with if everything is on the downside. Well, was this the direction? But if there are things that we see that there's been some positive advantages, that in fact, whether it's electronic or manual, there's always that pull away from that face-to-face care, but it's just something that we have to do. And now we have the added benefit of being able to aggregate that data. Before, we were taking time away from individuals and it just sat in a file or we couldn't communicate. And we have the ability to maybe make policy decisions that are more informed. It is very nuanced. I totally understand that direction and trying to capture those challenges and what it means for individuals and families. I would just ask that there be a little bit more context put around some of those questions so that we understand the full impact of a system change, and not just that one piece about the screen, but how did the transition from a manual and MSC role to the care managers and what that has meant for the sort of IT move.
And I don't want to monopolize this meeting, but Ms. Black, you've really, shuffled it down into a level that I am completely in support of, and I like that. I would like for us to develop something where we can measure this, because this all goes back into quality outcomes. But I would like to have it done independently, where an MSC care coordinator is not beholden onto their CCOs when you need to get to this data. It's completely anonymous, and that they feel safe in responding to that.
I hear what you're saying.
Thank you.
Anonymous and right. It's important. I understand that. Just to speak to some of the potential benefits of an electronically based care management system, I think you all kind of hinted at it, and my experience has been similar when I ran 7 practice sites across the state of New Jersey, and we were on paper, every site was an individual practice. And I would say in the context of care coordination, care management, every MSC was their own practice, because there was no ability for an MSC to link to another MSC to link to the larger organization. When data is available electronic across an organization, you can move from an individual practice model to a group practice model. So as individuals change geography, move from Albany to New York, or have different needs that occur over time. In our practice, I was able to go online, access our database, and manage patients at all 7 of the offices at any time of the day. So individuals who had med refills or med errors or acute needs, I could pull their chart up. So it supports coordination, but it comes at a cost. Care coordination organizations, I hope, can be responsive on a 24/7 basis and able to pull and access that data so that one individual can speak on behalf of the organization through a call system. It's a huge improvement when you look at after-hours accessibility and things of that type. So there are lots of things to look at, and that's why I called it trade-offs. It's one or the other. Thanks.
If I, in my other life, coordinated behavioral care, which Gary's very familiar with, as a health home, we did a deep dive with our CMAs around to care coordinators to find out what their life was like, and got some interesting data we're going to be sharing it with folks. And there was frustration with technology, but that's sort of normal, I'd say, because there's no good technology system that's perfect. Although we're in the behavioral health world, we're more experienced with technology. I think we were much more comfortable with technology and also data. But the one thing that we did learn was their frustration with not being able to access or manage the service providers in the, whether it's health or long-term care. So the frustration was less about technology, but more about inadequacy with respect to not being the payer and not being able to influence providers. And I use the big provider umbrella because it's an integrated product, so to speak, right? We're supposed to integrate health, behavioral health, long-term care, if you need MLTC services, for example. And I understand that because, and there's some other things that we've been working with OMH and DOH with regard to maybe some unnecessary paperwork, and we had more history though, right, with respect to looking at that. So one thing is a commitment, I think, if we could have a commitment to kind of really spending some time with CCOs to better understand, are there some things that we could lose, right, that really don't add value versus things that are absolutely necessary, notwithstanding some are required because of the federal regs related to what we have to do. But sometimes we add things to that aren't necessarily of value. The other piece of it from our deep dive was that the underlying providers are not interoperable, so they find themselves putting in data that's related to taking data from other providers, and that's just like a lot of work, right? That's like, how much work can a care manager do with respect to collecting data from the health world, from behavioral health providers, from long-term care providers, and be expected to put it into the platform? That's the care coordination platform. In our case, it's Metasced, right? For DD. So you think about that work, well, that's a lot of work, and they could find themselves really sort of managing data from all different sources, and trying to put it into care management platforms. So we should pay attention to that. But I think that probably the biggest, that was one of the big frustrations. The other one was really we don't have any gravitas with respect to holding providers accountable to work together or on behalf of the individuals that we are helping with care coordination. So that's what we learned, and we did it a pretty extensive. We actually have a report that's coming out that was based on this sort of deeper dive with the CMAs.
Sure. Well,
No, I was pointing to Arnold because he's had his hand up for quite a while now.
All right. All right. Well, thank you, Shamika. So, well, first off, I just want to say, obviously support everything Maxine's been saying. I think those are really important issues to look at. Managing conflict of interest of the reporting entities, I think, is going to be really important to make sure that you're getting really valid data that's in the best interest of those served. I guess I'd like to piggyback a little bit on, the point about some losses related to this heavy investment in data collection. I think it is just really important to look at that. And I think it's probably too early to make any determinations. Tamika, I think you're right. There's a learning curve and all of those other things. But I guess I'd like to make a simple point about that is, if we lose, respectful interactions and really the time necessary for those care managers to invest in outcomes, at the cost of just collecting the data OPWDD seeking, I don't think that's really a good equation at the end of the day. So the point I wanted to make was about an opportunity in terms of data collection, because the one thing, I think I'm a bit of a recent convert in terms of being more optimistic about data collection based on some recent meetings, and I know that there were some measures being taken and some anecdotal information about people's ER visits in some cases, which I know are something very easy to measure, yielding some real increased outcomes for them. So I'm thinking in terms of restrictive interventions, which I think would fall under the psychiatric behavioral health measures that you're taking. There's a real common concern with self-advocates that, many times people have too many restrictive interventions, and furthermore, that oftentimes the behaviors that drive those increases in interventions are environmentally driven, but that's never identified. So, like for example, let's say that I require a change in my medication because I'm unduly upset over time. You know, the treatment team would look at me and measure my behaviors, right? They would say, you know, well, Arnold's lashed out at someone, 20 times in the last month, or Arnold's cried 10 times in the last week. What they would not measure, and there's no mechanism for, is that Arnold was struck in the face by a peer at dinner 2 weeks ago. Every evening, the person in the room next door is quite loud, and Arnold has been unable to sleep. So what I'm wondering is, in terms of an opportunity, are we looking at ways to sort of measure restrictive interventions with a targeted outcome that they diminish over time if services are really of quality? And is there a way of collecting other data to try to connect those dots for people?
Sorry.
I hope that made sense.
No,
I thought a lot about how to make that
no,
kind of clear.
it did make sense, and also very timely. For part of this, I am going to defer to my colleague, Dr. Jill Pettinger, because the RIA system is under her purview. But we have been looking at this, and there's been quite a bit of work in that area. It's interesting to think about what we do measure and what we cannot always capture. But there has been intensive purposes, and we've been also looking at this on the incident management side and looking at things on how those may be relating to ER visits. We're trying to pull in some of those environmental things around other data sources and other issues that we're seeing. But I'm going to defer to Jill on maybe being able to explain a little bit more about what's being done with RIA and RIA data and what the RIA system is.
Yeah, and actually it's a good question, because this is, we've been working for several years now on reduction of restrictive or intrusive interventions, and primarily at this point have been focused on restrictive physical interventions. And we had a number of years ago developed and basically rolled out the restrictive intervention application, which is essentially a data collection tool that is under the incident review and management application framework. So in terms of how providers would go in and record information, it's specific to the use of a restrictive physical intervention. We capture several data points in the RIA system. RIA is our acronym for it. And it pertains to, what we're precipitating factors to the use of that restrictive physical intervention, whether there was any additional restrictive or intrusive intervention used in concert with what started as a restrictive physical intervention. So, for example, whether a PRN or stat medication may have also been used as part of that response to that behavioral event, and or whether there was a timeout room use. That's still a clinical intervention that is in some locations. That is a required data reporting element through our 633.16 person-centered behavioral intervention regulations. So all voluntary providers and state providers who have any plans that incorporate or are using in an emergency basis restrictive physical interventions have to record this data. There's a connection that goes over to IRMA in the event that a restrictive intervention may somehow result in a further untoward situation that results in anything that would then rise to the level of an incident under 624. So those things then become connected, if you will, in RIA and IRMA, so that there can be further review and analysis. So that's sort of the foundation was the regulation. We put out the framework of RIA and trained providers, SO and VO, on how to enter the data. And we had an initial year to year and a half period of sort of baselining, monitoring, making sure that we were addressing any issues around data implementation and recording. And so I think for the past couple of years, we have had some pretty consistent ability to look at who are the providers that are using restrictive physical interventions, who are the individuals. We're doing some we've done some significant review and analysis with regard to individuals in state-operated programs, because that's a universe that I have much more ability to sort of direct and manage, because I oversee our state-operated services. And so we do have ongoing basically steering committee and work groups at each of our state operations offices that involve clinicians and administrators, and essentially we have goals that we have been working towards, and depending upon the district determines what is their baseline, what is then our target for restraint reduction, things of that nature. So that's been a workload or work that has been in process for several years now. On the not-for-profit side, we have looked at the information. We have provided feedback to VO providers when we've identified certain concerns or trends. We have conversations with our colleagues in the Division of Quality Improvement to look into individuals or agency or particular program where we're seeing particular concerns with the numbers of interventions that are occurring. So that has been where we're at this point in time. And again, it's not a perfect process, because we're reliant upon the honest entry of data on the part of providers in terms of we're not there out in the field to know that in fact they are recording each and every instance of these interventions occurring. So we are reliant upon the ethical behavior of everybody that we have trained to, engage in this process. And again, when DQI goes out, they're reviewing, they're looking at, for their sample staff notes, if they're seeing indication of events occurring that are now not showing up in the restrictive intervention application. That gives us an opportunity to sort of level set, correct, and address those issues. I think we have seen some significant gains and improvements in restraint reduction, particularly in our state-operated programs. And again, that's something that we continue to work towards quality improvement around. So what you're talking about is sort of layering on additional data points. And again, our current restrictive intervention application doesn't have the sophistication to go down some of the paths that you were getting at. And that sort of ties back to our linkage back to our DQI folks, the Bureau of Program Certification reviews that are happening, because again, to the extent that we can learn about what appear to be concerning issues or trends relative to use of restrictive interventions in particular programs, then we can do a deeper dive when Bureau of Program Certification staff are on site. We also offer clinical consultations to providers when we're, again, identifying trends or concerns. BPC, Bureau of Program Certification, brings concerns to my team, and we then have further follow-up with specific agencies around how to best help them in a consultative way to address some of the challenges or concerns they may be experiencing and effectively supporting a given individual. But again, there's a lot more sophistication that really to get at where you were going.
Yeah, no, absolutely. Yeah, so I'd encourage us to take the opportunity to look at that as we develop a data system, and I would say expand that, because it's not just physical interventions. I believe there's a lot of people out there that are currently on psychotropic medications, for reasons of maybe environmental stressors and things like that. There's an awful lot of people on anxiety and depression meds, and if I lived in the congregate setting they did, I would think I would be anxious and depressed as well.
Before you decide, I want to go back to the agenda, because we've got two folks who came here to provide public comment. Would you be against our continuing this discussion for about 10 more minutes and postponing your comments, or do you want to make them now? Because it's the two folks who signed up to make public comment, I want to be respectful of the fact that we said that would happen at 12. So, you guys be willing to wait like 10 more minutes? That's okay? Give this group time to kind of wrap up, and then certainly, hear your comments. Okay? All right. I appreciate the consideration. So let's try to wrap our discussion up within the next 10 minutes and then hear from the public members.
Yes, hi. I wanted to go back to Yoel's point much earlier. The length of time it takes for families and individuals to get through our process is significant. And if we could have data on the length of time it's taking, say to get through eligibility determination, and getting through the front door process? And then how long is it taking from enrollment in the CCO, the life plan development, and actually connecting with the service? Because a lot of people have services in their life plan that they're not getting because of workforce issues and other factors. So how long is it really taking for people to get the service that they need?
The other thing with that is I'd be interested for the people that don't get through the first time and have to go through the process multiple times. Because sometimes people are denied the first round through for whatever reason. Yes, for eligibility. That's what I'm talking about.
So the issue of time is a measure that we can look at and tie that to all the processes you've identified and many, many more. I mean, typically that is addressed in the context of something like a quality improvement program where you say, here are the steps and here's the baseline data. It takes, let's pick a number, a month for eligibility to be determined. How can we change the steps, implement that new process, and affect a change over time? So you go back and you measure after you put in a new process and see if it's reduced from a month to 3 weeks. And then you change the process again and implement that, collect more data. So data is helpful in kind of setting baselines and then using it to inform a quality improvement approach. And it can be applied to all the specific processes that you mentioned, but to many, many others. I'm not fluent enough to be able to say we're using it for this process or that process, but it's something that we're looking at in terms of trying to be certain that people can access services in a timely way, whether it's through the front door or through the life plan or through their provider. Did you want to comment more? Because I know you mentioned CQI.
I can just at least reference with regard to the three-step eligibility process, Dolores, that we do track and monitor. I didn't look at that data before coming today to know what was the most current, but just as a ballpark, about 90% of individuals, 85 to 90%, are determined eligible at step one. Step one, typically, it can happen with a complete packet being submitted within a week's time because we have different staff who are reviewing eligibility materials, and sometimes they, have regular scheduled meetings, but the large majority of individuals are determined eligible at step one in that process, and it is fairly timely. The things that take longer are those individuals who need to go to step two or to our step three process because they are usually more complicated cases and or cases where the records may not be as robust to demonstrate whatever is the qualifying developmental disability diagnosis or the substantial limitations that the person may be experiencing or demonstration of those occurring within the developmental time period. So those tend to be the cases that take longer, but we have data and metrics that we can pull on those timelines.
I wanted to ask about a risk in terms of data. So connecting data to value-based payments over time. And I think long-term supports and services, I think that's a lot more challenging to measure than basic health outcomes. So specifically, I was thinking in terms of sometimes a provider of a service can act in good faith but not yield an outcome for reasons outside their control. Could be environmental. I think like a lot of cases in rural areas in our state, there may be less job opportunities or volunteer opportunities or whatever, opportunities in general. And I just fear, could there be a risk of going down a rabbit hole where, people acting in good faith are facing barriers and challenges to yielding good outcomes and then end up losing money as a consequence, and it's a vicious circle, and rather than improving quality of outcomes over time, right, it further compromises their ability to offer good services.
So let me talk about value-based payments because it's a little bit confusing. In some contexts, people talk about value-based payments incorporating risk, both upside and downside, meaning if there's a value that's created and the provider can share in that, that might be considered upside. But if there's no value or a decrease in value, the provider being at risk and therefore being penalized in some way. New York State, I think, incorporates the idea of one-sided risk or upside risk only, and I think that's a place where more people are comfortable than with full risk and downside risk to providers in particular. So I think the training wheels and the value-based payment methodology are upside only, and starting with that, and that would be certainly what I would encourage if SIP-PLs get to the point where they're looking at payment methodologies for their providers and want to explore risk, that the insurance companies hold the risk and the providers have incentives to create value, whether it's in terms of processes or outputs and outcomes. I don't think anybody wants to jump into the value-based payment methodology and put providers at risk. That would be very, that'd be something you'd want to do towards the end after people have had a better understanding and experience about what it means.
So do we know, which, yeah, that's my assumption, but what I don't know is, when rates are always getting adjusted over time, is it possible people are going to be in a situation where they're getting less than current rates, and it's really going to take those incentives to bring them up to the current rate standard?
We're not using value-based payment methodologies right now. We're using a cost-based reimbursement methodology. So in my sense of how that is working, providers have some protection against downside risk, and they're clever. They find ways to make a case to us that they need to be funded at a certain level to deliver the services that they're under contract to provide. We're not looking at value-based payments right now. We're, as we talked about, we're still kind of in a holding pattern around managed care. It's something that we'll probably have more discussions with our community at large after I think we get through the budget negotiations.
Thank you.
I just want to make a quick comment to build on a couple of things that have been said here. As you know, we've been a broken record about asking for data for years, and so we're very pleased to see this effort being so planned out. I just want to make sure that when we're looking at all of these data points, we're also looking at what we're not doing, like the difference between the services that are approved and the services that are delivered, and how that breaks out across. Because one of the things that you said, Dr. Kastner, was that our goal is to make the system more equitable. Our goal is to make it more sustainable, and we need to understand how and where we are able to deliver services and not able to deliver services, and bring that focus to the issues like the workforce problems, so that we can achieve those very lofty goals.
I agree, and thank you for the comment. Let me go to the two members of the public who have signed up. I'm sorry, I can't read. Naomi. If Naomi could start, that would be great. It's Naomi. No? So would you like to come and make your presentation? Or can you sit at that table with the microphone? Yeah, that would be great. The other way, sure. Whatever you're most comfortable with.
Would you rather sit there?
Yeah. You're cooking, I know a lot of them.
Everybody here is nervous too.
What?
Everyone here is nervous.
This is something you're probably not going to even think about what I wrote, but I did in everybody's comment, so this is what I wrote. How do you hear from parents and self-advocates in reference to quality of services? Can you hear me?
Yeah, can hear you.
Okay.
My next question is, how are you collecting data on this? Since I have been receiving OPWDD services before self-direction came about and after it, I have gone only 2 surveys in my entire lifetime. And the 2 companies that give me surveys are my parents, because my parents don't live in this state, okay? So out of all the years I've gotten services, I've only gotten 2 surveys. And what's weird, for me, writing this, is I discovered the 2 companies that are doing it are the least have to do with OPWDD services. Does that make sense? Mm-hmm. So, Living Resources, specifically their nursing services, I get a survey. And if I don't fill it out right away, I get another one the next day. Then if I don't fill that one out, I get another one. But that, I know Living Resources provides many services, okay? But it's only the nursing services, and it's, that's what I'm saying, is the least funded by OPWDD, but that's where I'm getting the survey from. And most people hear of Wildwood, Wildwood Agency. Now, that one, the only, and it's, again, it's like, it's the least involved, your adult education services, which mostly is not funded by OPWDD services, but that's the only place Mom and I get a survey to find out how it's going. It's the least having to do with OPWDD, but it's weird, because those are the only 2 companies in my entire lifetime that I get asked, how's it going? It's very detailed, both of them. But from no other agency, like I get supportive employment over with OPWDD, never been asked. All the agencies I've gotten service coordination, rehab services I've gotten from many different agencies, but nobody has ever asked us our input. And to me, when you're asking about data, I think to me, if you can't include people with disabilities directly, or the families, and to me somehow, that's got to be the most important thing. Does that make any sense what I'm saying?
Yes.
Absolutely.
So how do you get, and obviously from the people that know me, is obviously, I'm not shy. When you had public 5-year planning meetings, then I spoke, but so how do you get the data if you're not asking the families directly? How is the agency, how's the services going? Mm-hmm. And obviously, and if I don't understand it, sometimes they say, do you want to do anonymous or put your name on it? But it just seems weird. The agencies that get totally supported by OPWDD, I have never heard in my lifetime from our input at all. It just seems a little weird to me.
She's getting 10.
Well, thank you for that comment. And just, I know there's a question that you asked, which is, how do you get the data if you don't ask for it? And obviously, you know, the answer is you don't get the data. So if we don't ask individuals how they feel about the services that they receive, then we don't know. So you're right, we have to start asking the question and giving our individuals and families an opportunity to tell us what they value and whether the services are actually meeting their needs.
And make sure, like I'm separated from my parents, so sometimes what I hear, take it one step further. If the individual lives with a family, or even not, you have to think about that, because sometimes it'll send to sometimes the individual is living with the family, and you should still ask the individual, plus the family. And Wildwood, the Adult Act, is the only one that will make a decision. It's a good decision, I think. They said one to my mom, one to me. You're going to get 2 different answers. I trust you, you will. If you send it to a parent, send it to a self-advocate. And when Mom fills it out and when I fill it out, it's totally 2 different answers. So I'm glad they do send it to Mom, even though she doesn't live in New York City. Just wanted to put that thought in your brain.
All right, thank you.
Thanks.
And then Laura Kessel is going to speak next.
Hi, thank you for the opportunity. I'm Lara Castle. I'm the coordinator of Medicaid Matters New York, which is a statewide coalition advocating on behalf of the interests of real people in the Medicaid program. I think Naomi is your name, right? Yep. I was going to say much of what Naomi said, so I think I'll just leave it at that. I think she delivered the message pretty clearly that if you're going to measure what's happening in the system, you really need to ask individuals and families, and clearly ask them separately, as she made the point, because you may get different answers. So I'm not going to say much more about that because I think Naomi did a really good job of making that point, and others around the table have made that point as well. But I will say that we are not naive to the fact that data takes time, and it's costly, and it's complex, and it involves a number of different providers at every level, and a number of different, when you enter in addressing social determinants of health, entering in the providers that are not currently Medicaid or not currently in the OPWDD system. So as Donna said, this is like baby steps, like we're getting there. There has to be a starting place, and I applaud the agency for making those steps and making the commitment to have Tamika on staff and have a dedicated department to it. And as long as we can continue to make progress as it relates to measuring what's really happening with people and their experiences and their satisfaction with their services, I think hopefully we'll get there. I'm glad that Gary mentioned the OMH data experience, and one of the things on the advocacy side that we've seen is there is in particular a dashboard that many advocates have looked at on the OMH side for a couple of years now that's very useful, that I would encourage you to look at, is the OMH HCBS dashboard. It's intricate and complicated, but we've learned how to read it, and we've learned how to glean information from it that gives a glimpse into what's actually happening on the ground. So I think it's a nice example of how you can have complex data that could actually make sense to people like me, who I'm not a data person, I'm not a finance person, but I and others, again, we've learned how to read it. So that OMH HCBS dashboard, I think, is a nice model. Another good model to potentially consider are the DISRIP dashboards. As someone here, or maybe multiple people have said today, there's not going to be a perfect thing ever related to data, collecting it, reporting it, making it public. It's just not going to be perfect. And, the HCBS dashboard isn't perfect, and the DISRIP dashboards aren't perfect, but I think those are two good examples of some public-facing data that's actually accessible and meaningful and usable. I think when it does come eventually to publishing data, that it will be important to make sure that there's some type of accompanying how to read the data document or tutorial, or something that allows people to actually know how to read what they're seeing online or wherever. Again, we've learned how to do that. It's been sort of slow, but I and others in the advocate community have sort of learned how to do this, and learned how to, really think critically and be like playing data geeks, even though we're not really data geeks. And then the other point I'll make, I'm really glad that Arnold mentioned value-based payment, and I'm glad that came up here today. I think it's really important to remember that the value-based payment clinical advisory group work toward quality and quality metrics needs to be captured in all of this, and it needs to be thought of in conjunction with the data collection, because what we capture in the data, what we collect and report as it relates to data, is all going to need to be important in that discussion. So I'm glad that came up, and I would encourage that to continue. Thanks again for the time. I appreciate it.
All right, thank you.
Lara, I really thank you for the points that you've made. when I talked about the data strategy and the last part of it being open data and public-facing displays, we are very familiar with the OMH data displays, and I've had conversations with staff how they achieved those displays, and we're looking at trying to get the tools to do that here in OPWDD. So we've been also looking at the same thing with Disrupt, and having conversations with DOH on that side and their data management folks. So thank you for bringing those to our attention, because it's, we find it useful. We're like, wow, look at what that other state agency is doing. But it's great to know that individuals and families and advocates find it useful too, and that might be a direction for us to pursue, and their support for that. The other thing I wanted to talk about was VBP. And Arnold, thank you for your comments. One of the things the CAG really is focusing on is something known as attribution. Who's really responsible for the delivery of care? Who's responsible for the improvement of care? What happens when there's unintended consequences, when we put measurement in place? These are not easy questions to answer, but they're under discussion. And I think the fact that we keep raising them and keep having this dialogue is very important, so we won't lose sight of these important components of thinking about measurement. And I really appreciate, I think what I'm going to take away most of is that there's support for the progress. And there's understanding that this is iterative, and that we'll continue to have this feedback loop about where we're moving forward and where we're having challenges, and continuing to work together. So thank you, everybody, for your comments today.
All right, and with that, I think we'll conclude the meeting. Thank you for many of you coming from a great distance, and we appreciate your participation. Thanks.